and co-edited Protocols in Neonatology with Professor Irfan Wahid. These books, no doubt, have been especially written for the neonatal clinician, especially in Pakistan. And Professor Haque is, no doubt, he's continued to supervise and mentor masters and PhD students. And he's a reviewer of 12 international journals and the visiting professor of 4 universities. And one of the more important thing is we always found Sir active and always helping. So over to you, sir.
Bismillah. Thank you, Vikram and Dr. Nazir. I'm very grateful for your invitation to talk about necrotizing enterocolitis, which remains a continuing enigma. You would have all, if not all, most of you would have attended or heard Professor Joseph New at the Saudi Neonatal Society meeting, his review on necrotizing enterocolitis. I will give a much more pragmatic review, but at the very onset, for my younger colleagues and perhaps even for the senior colleagues, I should say that NEC is a Gorak Thanda. It really is a very big Gorak Thanda. And that's what I will try and explain to you why I have given the title that NEC is a Gorak Thanda. I have nothing to declare and there is no conflict of interest. Now, NEC is a devastating disease, particularly for the very fragile and very tiny preterm infants. Though we have known it for nearly 200 years, and for the last 60 years, we've been trying to find its etiology, define its pathophysiology, define it, necrotizing its enterocolitis itself. But despite all that, we haven't really made very great success, and we have not found any cure so far with all this work going on. But there is a lot of work still going on. So the objective of my talk is to discuss some newer concepts in our understanding of the NEC pathophysiology, whilst keeping the talk clinically relevant, because I think that's the most important thing. Theory is important, but clinical relevance is important. So what I will do in this 45 minutes or so is to describe the scope of the problem, what NEC is and what it is not, and who is at highest risk of developing NEC. But more importantly, I want to spend some time for my younger colleagues and maybe even for some of my senior colleagues to try and understand the changing pathophysiology of necrotizing enterocolitis, particularly the role of gut microbiome, genetics, and immunology. And once we finish that, then I'll talk about diagnostic clues, which we all know how to diagnose, or we think we know how to diagnose necrotizing enterocolitis. And once we diagnose it, how do we best manage it? And last, in 2 slides of where the research is taking us, what is the direction of travel? So the scope of the problem is that NEC is a universal disease. It happens all over the world. The incidence in Europe is between 3 and 10%. In South America, between 8 and 11%. Much lower in Australasia, about 5%. But interestingly, if you see the figures I've given you, about 6 or 7% in North America, but 20 to 30% of these babies die. It's the same number of babies who die as the same number of under 15 children who die from cancer plus meningitis. So NEC has is a great killer of newborn babies. And that's important message to remember. The only study I could find from Pakistan is from Hashmi et al. In JPMA from Aga Khan University Hospital, where they quoted an incidence of 9%. Now, I recognize before people jump on me that I've given you such high incidence. I know that many individual units have reduced the incidence of NEC. Our own unit, we had an incidence of 3%. But what is correct even today is that neonatologists all around the world still continue to overdiagnose and overtreat, in inverted commas, what they call NEC. And just in the United States, each case of NEC costs around $500,000. And the overall cost of NEC in US is between $500 million to $1 billion. So it's a very, very expensive disease. Now, why is this so? Because we as neonatologists, if you get a baby with slight abdominal distension or increasing aspirate, we don't know what is going on. We're not sure. So we label it as possible NEC and start treating it as NEC. But of course, people forget that treatment involves nil by mouth, broad spectrum antibiotics, blood tests, and TPN. And all this costs money. And moreover, more than money, the role of antibiotic, it changes the gut microbiome, and that may have a lifelong effect. And recent papers have appeared where they have shown that changing the gut microbiome in the newborn period has an effect on behavior and attitude later in life. When we have nil by mouth, we don't give any enteral stimulation, so there is continuing gut injury, and the gut integrity is continuing to be lost. Of course, we try and give as much nutrition as we can through TPN and whatever, but you will find that most of these babies go on to develop extrauterine growth restriction, and then that may affect them for all their life. So actually, our overdiagnosis and overtreatment of NEC may be increasing the morbidity while we're trying to treat what we perceive as NEC. So why is this so? There are two main reasons. One is most clinicians still have the conventional understanding of the pathophysiology of NEC, and I'll discuss that in the next slide. The second is there's a lack of clear definition of NEC. So what is the conventional pathophysiology concept? It is the concept of diving reflex. When you dive deep into the water or deep into the sea, as fishes do, you hold your breath, you get a bit hypoxic, and what happens is the diving reflex, the natural phenomena is to send blood to the brain and the heart and the liver, and the gut becomes ischemic because the blood is preferentially sent over to the brain and the heart. And if there is bacterial colonization at the same time and macronutrients, particularly from formula feeding, that is a recipe, or that was considered to be the recipe for developing NEC. But of course, now we have got huge number of very variables, which are we now know may be responsible or contributing towards the development of NEC. There are three things which are the most important, and those are the three things I will stress on. One is the intestinal immaturity. Two is the excessive immunoreactivity of the intestinal mucosa. So once you have intestinal immaturity plus excessive immunoreactivity to the bacteria in the gut or to the macronutrients in the gut, these three things combine to give you NEC. And as I said, there is a lack of precise definition. Here are 7 babies I have put together with their 7 X-rays, and they were all labeled as NEC. Only one has NEC. Can you tell which one? Rather difficult. And that is our problem. That is the problem why people lump all the abdominal distensions and ileus or whatever they see in radiologically and label it as NEC. So we are overdiagnosing NEC. And interestingly, in literature, if you try and look for definition of NEC, there are about 8 definitions. And Ravi Patel at a meeting which was basically for reviewing NEC, and this was US neonatologists were attending it mainly, who had interest in necrotizing enterocolitis. And Ravi did a small survey and asked them what class definitions were they using. We surprised, less than 5% were using the original Bell's classification or Bell's staging. Most were using the modified Bell staging, but the question is, which modification? There are at least 3 modifications that I know of, but there are more. Not surprisingly, because it was a US meeting, only 2% were using the definition used in the United Kingdom. But only 20% were using the Vermont-Oxford network definition of NEC. No one was using the CDC definition. And surgeons were much more keen to use what is called 2 out of 3 definition. And I will show that to you in the next slide. Nobody was using the Stanford definition or the International Neonatal Consortium definition of NEC. But for me, what was the most interesting is that 18% or so of these clinicians were using their own definition of NEC and not the 8 already published in the literature. And that is where one of the difficulties is, how do you diagnose NEC? So for this lecture, and for me, as I understand it, the definition of NEC is an idiopathic inflammatory bowel disease mainly seen in premature infant that involves the small and the large intestine, and is characterized by cognitive necrosis. And that is the important factor, that there should be cognitive necrosis. The problem is that how do you know there is cognitive necrosis unless you go and open up the abdomen and see the intestine? There should be inflammatory changes, bacterial overgrowth, pneumatosis intestinalis, and perforation. So that is the basic descriptive definition of NEC, which I'm going to use for this particular talk, and this is the one I use for clinical management. The 2 out of 3 rule, which Sheila Gephardt and colleagues of pediatric surgeons suggest, is that if 2 of these 3 things are present, pneumatosis intestinalis or portal gas diagnosis, persistent thrombocytopenia for 3 days or more, and postmenstrual age at disease onset more consistent with NEC, and we'll talk about that in a minute, than spontaneous intestinal perforation. So the major differential diagnosis really, the surgeons want to differentiate, the physicians want to differentiate, is between SIP, the spontaneous intestinal perforation, and NEC. And the way to do that is very difficult, because in SIP, there is a focal rupture of the muscularis, there is no inflammation, there is some hypertrophy, there is no necrosis. The ileum is commonly affected, there is no inflammation, there is no evidence of spread of infection, there is no ischemia, there is no pneumatosis. But even then, it is extremely difficult, and it occurs a little earlier than when you see NEC. And it is much more less, the mortality is much less. And if you ever grow an organism, you're likely to grow Candida or Staph epidermidis. The risk factors are prenatal and postnatal, particularly if you have chorioamnionitis, preeclampsia, if there has been a knot in the placenta causing hypoxia, that would give you much more likely to give you a SIP rather than NEC. And of course, it is very closely related to the medications which we use frequently in neonatology. Now, the only saving grace, clinically it is very difficult. The only saving grace is a recent work and published by Son et al. In Nature only a couple of months ago, where they have used machine learning. And machine learning tool can be applied, and that can differentiate between SIP and NEC very, very well and quite clearly. So we are hoping that this tool will become universally available and we'll be able to differentiate between SIP and NEC. What other conditions masquerade or pretend to be NEC? Viral enterocolitis, usually associated with formula feeding. It is a lymphocytosis. It's also an immunological disease, but there is no necrosis and there is variable mucosal damage, not the universal damage which we see in NEC. The other is milk protein-associated colitis, which is sensitivity to cow's milk protein. And this is due to eosinophilic recruitment in the mucosa. Now, you would remember from conditions like and other conditions where the granules of eosinophils are very toxic. And when the eosinophil ruptures, it causes toxic damage to the mucosa by the eosinophil granules. That debate about whether transfusion-associated NEC exists or not exists, but it is thought to be due to presence of antigen to intestinal epithelial in the transfused blood. So if you have antigen to the epithelium of the gut of the newborn baby, then you would get transfusion-associated NEC, so to speak. But I'll tell you about that also in a later slide. The most common reason why babies go on to develop NEC is because of delayed feeding or antibiotic associated, because because of delayed feeding or giving antibiotics, you change the gut microbiome and you cause dysbiosis that is the change in the gut microbiome, and you get exaggerated immunoreactivity. And I will spend some time explaining that to you, what this means. And this causes, of course, ischemic damage to the gut. Then there is the other condition, which probably is quite separate, and that is due to left-sided congenital heart disease causing hypoxic injury to the enterocytes, because there is universal hypoxia. The enterocytes are hypoxic, and this leads to proliferation of bad bacteria, and this causes a colitis. So these are about 5 or 6 conditions which masquerade as NEC, and it's sometimes very difficult to differentiate between them. Who gets NEC? We all know that. This is a slide from a textbook. You will know this. You can get this from any textbook, and I'm not going to go over it, except to tell you that they are all interrelated. Prenatal birth and postnatal, for example, if the mother has a poor gut microbiome, if she has much more bad bacteria in her birth canal or in her gut, that is going to be transmitted to the baby, and the baby is going to start with a greater load of bad bacteria rather than good bacteria. So it's all interrelated with each other. The question is, when does the baby get NEC? The most frequent gestation when babies you see NEC is something between 28 and 32, 33 weeks. There's a peak at around 31, 32 weeks, and this is when you see NEC most often. The problem is also, and the very interesting issue is, the age at diagnosis is inversely related to gestational age. So the smaller the baby, the younger the gestation, the later the NEC is going to develop. So if you have a 23-week baby, that is going to take 4 to 6 weeks for NEC to develop. Whereas if you have a 29-weeker, maybe 2 to 3 weeks. Whereas a term baby, where NEC is infrequent, but if they were to develop NEC, then it takes a couple of days for them to develop NEC. The question I want to ask you and for you to think about is, why is this so? Why do preterm babies get NEC much later, whereas nearer term or term, as you increase the gestational term, the NEC appears earlier and earlier? Because both of these babies, preterm baby or near-term baby, both of them have got intestinal dysbiosis. There's the bad bacteria has increased in number. The reason is that in preterm, NEC is mainly due to immunoreactivity. So it's mainly an immunological disease. Whereas in the term infant or near-term infant, it's mainly due to vascular reactivity. And so some people have actually said that the necrotizing enterocolitis in a preterm versus a necrotizing enterocolitis in a term baby are 2 separate diseases. And I'll try and explain that to you, why that may be to some extent true. So let us try and understand the major players in the development of NEC. There are just 4, not more, there are just 4. Gut, the physical and chemical barrier. The gut offers to protect itself from the microbiome, the bad bacteria. The microbiome itself, gut immunology and genetics, and the gut intestinal blood flow. So those are the 4 reasons which are the main players for necrotizing enterocolitis, and I hope to discuss one by one with you. Let us start with the gut structure. One of the most important barriers is the mucus layer over the epithelial lining of the gut. And this mucus layer is of 2 densities. The upper layer is thin, the layer below is thicker. And what it does is it protects or prevents the bacteria from getting in contact with the epithelial surface of the intestine. So the gut mucus layer is extremely important. The second is these cells have to be bound to each other. The epithelial cells need to be tightened to each other, and they are bound with what is called the tight junctions. And the tight junctions start to develop from 25 to 26 weeks and then onwards. So the gut, the cells become tighter and tighter as the gestation increases. And therefore, the gut is a little leaky to start off within a 23, 24, 25 weeker. Then there is the goblet cell. The goblet cell has a major immunological function. It regulates the barriers. It regulates the gut integrity. But the most important cell in the gut, as far as NEC is concerned, is the Paneth cell. It contains antimicrobial peptides, immunomodulators, and it impacts on what is happening to the gut microbiome. What has been found on histology is that infants who go on to develop NEC have fewer Paneth cells. Now, one of the roles of the Paneth cells is to secrete epidermal growth factor. That is the growth factor for the enterocytes, the cells to grow, the so-called trefoil factor. And it also starts to increase from 26 weeks onward. So again, the repair capacity of babies at 24, 25 weeks is not so good because the epidermal growth factor is not that high. The epidermal growth factor decreases because it increases the tightness and the growth of epithelial cells, prevents the bacteria from going into the circulation or translocating through the epithelial cells of the gut. Excuse me. The second is the microbiome itself. We all know that for you and me, the gut microbiome are extremely important for our good health. If it changes to more bad bacteria, we suffer from disease too. And so what happens, what do good bacteria do? They strengthen the gut, they tighten the tight junctions, they produce metabolites like arginine, glutamine, and short-chain fatty acid that protect the enterocyte from damage and injury, and they dampen down the immunoreactivity in the gut, as I will show you in the next couple of slides. They also have a much greater binding affinity with secretory IgA. If bad bacteria become preponderant, they become more, this is so-called dysbiosis, all this is reversed. You have the tight junctions become loose, the bacteria can translocate very easily and into circulation, and that causes damage to not only the gut, but also the endothelial cells of the intestine. And this has been shown beautifully by one of my previous trainees, Pami Mohan, who is now a professor at Baylor. And he showed that prior to development of NEC, there is a change in the gut microbiome. It occurs suddenly. And just like a flower blooms, the sudden bloom of the bad bacteria, the protobacterium, from being in minority becomes the majority. And so what you have in NEC is that there is much more bad bacteria than good bacteria. And that, I think, is very important to remember, that this dysbiosis is taking place at the time when we are diagnosing or treating NEC. But the microbiome are not just simply in the gut, they have a very close relationship with the brain, so-called gamba, the gut microbiome brain axis. And what that is, because the gut microbiome has an impact on what is happening to your neuronal growth and to your brain growth. And you will see that this has been shown that surgical NEC, if you have surgical NEC, it increases the risk of cerebral palsy, it increases the risk of mental development impairment, physical development impairment, and neurological development impairment. So the change in the microbiome is an extremely unhealthy thing to have. And so, unfortunately, this is what happens in NEC. Coming to genetics, yes, there are some babies are genetically predisposed to developing NEC. Babies who have a significantly higher IL-18, 6 or 7 AA genotype, these are the babies who go on to develop stage 3 NEC, significant or serious NEC. Some babies also genetically have less IL-4 receptor gene. The IL-4 receptor gene is a protector gene. It protects the gut from injury. And by converting and producing more Th2 helper cells, those Th2 helper cells protect against the development of NEC. So if you have a combination of IL-18AA genotype plus the deficiency of IL-4 receptor gene, then you are much more likely to develop NEC. And this can be studied, and you can predict which baby is likely to develop NEC if you do study the genetic markers. But what I want to concentrate and what is important more, because it gives you a greater understanding of how NEC develops. So the immunology of NEC, there is altered or dysbiosis, there's maybe antibiotic therapy, nil by mouth, but it increases the bad bacterial activity, which signals, sends signals down, and then because accompanying the immature intestinal barrier, which I have discussed earlier, along with the exaggerated presence of elevated expression of TLR, toll-like receptor 4, which is important for gut development and injury. And this TLR4 then increases and causes exaggerated inflammatory and tissue injury, leading to intestinal necrosis and necrotizing enterocolitis. For some of my younger colleagues who may not know what toll-like receptor 4 is, toll-like receptor is a receptor of the pattern recognition family. So whenever you and I get an infection or a foreign bacteria or a foreign antigen, our body has got pattern recognition molecules which recognize that and then try and block it. And this is a signaling receptor that is necessary for hemostasis of many epithelial cells, whether be it in the gut or the urethra or the vaginal canal or in the lungs. Now, what happens is that you have these bacteria releasing toxins. They are interacting with TLR. TLR then signals and causes a calming sequence. It has two actions. It is polymorphic, so it causes hemostasis. It balances the hemostasis, and it also causes repair if there has been any injury. But if there is unchecked TLR release, there's too much TLR, then there's loss of this balance, and a loss of this balance causes increased injury and poor repair. Now, that is okay. Why does it happen in the preterm infant much more than in the term infant or any other infant? The answer is very simple. The TLR development starts at around 20 weeks and reaches a peak at around 34 weeks. And when the TLR is increasing, that is the time when you get necrotizing enterocolitis most often. So that is the reason why you get necrotizing enterocolitis much more so in babies born between 25 and 31 or 32 weeks of gestation. So that gives you an explanation, an immunological explanation, why we see NEC when we see it. Now, what does TLR actually do physically and chemically? It interacts with the premature gut and the abnormal microbiota. It then causes damage because of its hyperactivity. It is very active. It is higher in amount, and it is highly immunoreactive. It causes damage to the mucous layer and to the epithelial layer, and then this increase, it also affects the endothelium of the blood vessel, gut blood vessels, particularly the capillaries and the mesenteric blood vessels. Because TLR4 suppresses the release of endogenous nitric oxide. Nitric oxide, as you know, is a vasodilator. When you suppress that, you get vasoconstriction. So the mesenteric blood vessels constrict, and there is lack of blood supply to the gut and ischemia, and this cycle keeps on going, and that is the reason why you have a progression towards necrosis, and the preterm infant has not got the ability to down-regulate TLR4. So as far as term infant is concerned, because the TLR has reached its top and is coming down, has got the ability to reduce the TLR upregulation, but preterm infants do not. And that is one of the reasons why preterm infants get much more severe NEC. So to summarize the TLR polymorphism, there are stressors which increase the TLR and lead to necrotizing enterocolitis through the Th2 lymphocytes, which I talked about, and there are protectors. So if you have more stressors, you will get necrotizing enterocolitis. If you have more protectors, you will not get necrotizing enterocolitis. So it is important to try and get the TLR down to normal levels and to have an equal balance so that there is the right amount of TLR is available for repair of the gut rather than injury to the gut. One last science, and then we will finish science, I promise you, and that is the IL-22 in the gut. IL-22 is also very important because it is present in the mucus layer, it is present at the epithelial margins, and it is lacking in premature infants. That is not what is important, why I want to discuss this, but the importance I want to discuss this is that the recombinant IL-22 has been found. If you give that to mice, it protects the mice from developing necrotizing enterocolitis. Mahi et al. Showed this last year. What they did was to give recombinant IL-22, and you find that the tight junctions become tighter, the cellular epithelial damage becomes less, there is epithelial regeneration, and the inflammation is down. So that is another new modality which may become available for human experiments and for human use much later in coming years. Last but not least, but this has nothing to do with immunology, this is to show you the difference between term NEC and preterm NEC. In term and near-term infants, it is the failure of the compensatory autoregulatory mechanism, the diving reflex, which I discussed earlier, to preserve the intestinal blood flow secondary to hypoxia, ischemia. And so there is hypoxia and ischemia in the gut of the term or near-term infant, and that is what gives them NEC. Whereas in a preterm infant, the arterioles fail to dilate because of suppression of endogenous nitric oxide on the influence of the TLR. And also in the developing blood vessels in the mesentery, the submucosal vessels in the preterm infants with NEC have a higher concentration of endothelin-1, which is a vasoconstrictor. So they have much more vasoconstrictor, and they also, the TLR is suppressing the vasodilator. That's why they get much more ischemia and much more serious injury to the gut. And this is what we see, and this is what we subconsciously believe in, and therefore when there is absent or reversed end-diastolic blood flow, we stop feeding or do not feed these babies, but it is less common in very preterm babies. But the clinical practice is strong, but the scientific evidence is very soft. In fact, the meta-analysis does not show that it makes any difference whether you feed them or you don't feed them, or when you have umbilical catheters, whether you feed them or you don't feed them. But what does make a difference is giving antibiotics. If you give antibiotics, you start changing the bacteria and the microbiome in the gut very early as within 48 hours. So even when we talk about empirical antibiotic therapy, and that it does not cause any problems, it does, because it changes the gut mucosa, and it makes the bad bacteria more predominant. Interestingly, there was a study from China 2 years ago, which is fascinating, which I don't understand, which most people don't understand, and most people don't really believe it, is that they actually showed that giving antibiotics was protective against necrotizing enterocolitis. This has to be repeated. This is a very controversial study, but I just wanted to put it there so that the seniors amongst you, Dr. Nasser and Dr. Junaid, who are always very astute in pointing out these things, may say that I did not show this particular study. Now, I said I mentioned a little bit about the blood transfusion-related necrotizing enterocolitis. The meta-analysis, earlier meta-analysis showed that there was a relationship between transfusion and necrotizing enterocolitis. But again, Ravi Patel's work has shown that it is not the transfusion, but it is the anemia. If you let the babies become anemic, then they are much more likely to get NEC. So if you don't, and a paper has been just published, I think this month or last month in Archives, giving values when you should or when you should not transfuse a baby. Just as a sideline, because I found it very interesting, transfusion, if the transfused blood is coming from female donors, particularly elderly female donors, that is much more safer and much more protective of NEC than transfusion and the transfused blood coming from male donors. I don't understand why this is so, but this is a recent meta-analysis which has been published, which is rather interesting concept. So let us finish with signs and summarize what happens in NEC. You have dysbiosis, predominantly unfriendly bacteria that break the blood and the gut barrier, and then that increases TLR signaling, and which causes activation of cytokine, apoptosis, breakdown, and bacterial translocation, which leads to the endothelial vasoconstriction and continuing cycle, which causes intestinal ischemia and necrotizing enterocolitis. You can stop all this if you want to, giving breast milk. Some people say also by probiotics, but of course with TLR inhibitors. Clinical signs and symptoms. Often NEC comes as a surprise. The baby is doing well, and suddenly you find that the baby is popping up, a big abdomen, and the baby is very, very unwell. But we all know the signs and symptoms of necrotizing enterocolitis, or diseases which mimic necrotizing enterocolitis, both intolerance, abdominal distension, blood in the stools, thrombocytopenia, ileus, or whatever. But interestingly, some people have started looking at when these signs appear. If you look at the 50% rate, the earliest sign in the 24-week babies is intramural gas. In babies who are much older, it takes much longer, and the portal venous gas appears much later. But what is important, as it is important in late onset sepsis, is the change in heart rate variability. And that has been shown recently to be a much greater predictor of developing NEC. And that is something, if you have a heart rate or hero monitor, then you will be able to use that. Those people who do not have, and people have started looking at what other methods can we have to diagnose or predict NEC. The heart rate and saturation I've talked about, which was by Fairchild. There is a scoring system based on baby's behavior, cardiorespiratory and abdominal findings by Jenny Fox. And there is a nursing tool based on gestation and feeds and risk factors. But the most frequently and more a tool which is getting more popular is so-called the gut check NEC. It has 9 risk factors, and it evaluates the risk based on those 9 factors, and it has some credibility. And I think people need more studies need to be done before it becomes universally available. What for us who do not have those tools, the 4 tests which are important. Thrombocytopenia, sensitive but not specific. The intestinal fatty acid binding protein, sensitive and highly specific. IL-6 and IL-8, sensitive but low specificity. The calprotein, high specificity, low sensitivity, and cerebri EGF, high sensitivity and high specificity. And here is a study showing the thrombocytopenia is persistent, whether you have medical NEC or surgical NEC. If you look at calprotein, specificity is high, but the sensitivity is low, but it has high positive predictive value. And intestinal fatty acid binding protein increases with NEC as NEC develops. We normally use radiology. Unfortunately, the sensitivity and specificity is only about 40%. And to my surprise, reading the literature, about 35 to 40% of perforations are missed on plain radiology. Ultrasound is gaining importance and is very good technique, but it is operator dependent. And if the operator is good, you can make the diagnosis very easily. But if you're learning, it is a learning curve. And once you learn the technique, then it is easy to diagnose. What about using classification and staging NEC? There have been, at least, as I said, Bell's classification, the original one, which was focused on clinical staging. Modified Bell's, there are 3 at least, and the idea was to have a clean data set of other conditions versus NEC. Then there's Gordon's classification, which basically tried to separate NEC from SIP. And then there is the acquired neonatal intestinal diseases classification, which focuses on risk factors. So there are many classifications which are used. I personally have suggested this in 2016 in our paper, simplified it very simply: suspected NEC, medical NEC, surgical NEC, and you can read the details about this and the study on this in our paper. So coming to final closing sessions of this talk, what are the treatment modalities? And this has not changed since the 1960s. Since I started doing neonatology in 1968, this has not changed. The idea is to normalize the hemodynamic rearrangement. If there is a baby in shock, you need to treat that, minimize the progression of disease, removal of dead intestine. But how do we do that? Resting the gut. So we stop feeding to minimize bacterial translocation. The question is, for how long? Nobody knows. Most people do it for 10 days. Some people do it for 7 days. Some people like us, we were doing it for 5 days. Reduction of infection, starting antibiotics. Okay, which antibiotics? For how long should we give antibiotics? Should we be adding antifungals to these, to our management regime? Don't know the answer. Removal of necrotic gut. Should we drain or should we do laparotomy? Once again, no, don't know the answer to that. But what we do know is that human milk reduces inflammation and repairs intestinal injury. Hence, human milk feeding should be initiated as early as possible. Question about use of probiotics and lactoferrin is debatable, and there are new anti-inflammatory and amniotic fluid and stem cell therapies. And let's go through one of quickly, the resting the gut. Now, I showed you in my enteral feeding talk that resting the gut is, if you don't feed, you promote a villus atrophy, you promote dysbiosis. So feeding is good, but of course in necrotizing enterocolitis, we are between the devil and the deep sea. What do we do, whether we should feed or we should not feed? Most people will opt not to feed. But very importantly, as again I pointed out in my entrance nutrition talk, the introduction of a standardized feeding regimen, particularly from Australia, has shown that they were able to reduce the risk of NEC by 87%. So no matter what you do, ladies and gentlemen, do have a standardized feeding regimen. Breast milk. There is loads of meta-analysis showing exclusive breast milk is protective against NEC. Even partial breast milk is protective against NEC. For every 10% increase in formula milk, there is a 12% increase in NEC, 20% increase in surgical NEC, and about 18% increase in late onset sepsis or sepsis. Now, there are those reasons, there are many, many other, but the main immunological reasons why human milk is protective is because human milk dampens down the TLR, which I have talked about. It has more secretory IgA. It has lactoferrin, which covers the mucosa and protects the bacteria coming in contact with the epithelium, and the presence of oligosaccharides. Now, we'll discuss that in just 1 second because I think that's very important. The human oligosaccharides are unique to humans. They are not found in animals. Some vegetables have them, but these are unique to humans. And not only unique to humans, they are unique to mother and baby dyad. So the oligosaccharides from one mother to her baby are combined, whereas to another mother, it may not be useful. But what are these? These form about 13% of the solid component of breast milk. There are about 200 of them. They are not digested and provide no energy, but are necessary for gut integrity and controlling intestinal immunoreactivity and growth of good bacteria. As I said, they are influenced by the genetics and the mother and infant dyad. But what is most interesting? Is the recent finding that a particular oligosaccharide, the so-called diacetyl tetrose, DSLNT as it is called, is much lower in babies who go on to develop NEC, and certainly even lower in babies who go on to develop stage 3 NEC as compared to stage 2, and babies who do not develop NEC. So herein lies a dilemma. How do we get a DSLNT into the baby? If you use donor milk, the donor milk comes from mature mothers who have delivered full-term babies. And in them, the oligosaccharide levels are much lower, as I showed you in my previous talk. So we need to use preterm milk, human milk, to feed these babies. Or if we can isolate this particular oligosaccharide and try and see if we can add this to the milk, whether it will be protective or not. Here is another likely progression where research will take us into protecting NEC. We always, all of us, do TPN initially when we diagnosed necrotizing enterocolitis. As I said, how long do we do TPN for? When do we start enteral feeding? When do we start trophic feeding? Don't know. As I said, 7 to 10 days is the traditional way. We did it at 5 days, but I don't have evidence to say that our way was better than or worse than any. But the dilemma of TPN is, of course, if you don't have anything going in the gut, the bacteria find it easy to translocate through the epithelium. What about probiotics? There have been large 56 studies and 30 observational studies. Nearly 87,000 babies have been studied. The usage is very variable. The highest use is in Europe, and the lowest use is in South America, of course, because of cost, but it's also not used very much in the North American continent. It is used quite a lot in Australasia. I just got this figure from the Middle East. I think they are starting to use probiotics gradually. Probiotics are very useful. They decrease adhesion, they increase tight junctions, they increase IgA, they kill pathogenic bacteria, and they dampen inflammatory response. So there is some evidence to support the use of probiotics. And the last meta-analysis by Sharif showed that if you use lactobacillus plus bifidobacter, it reduces NEC and it reduces mortality. If you use just lactobacillus, then it reduces NEC, but not mortality. And this is from the European consortium, where before the era of starting probiotics, the NEC rate was this. Once they started routinely using probiotics, the rate fell. And this is true for babies under 25 weeks and babies between 25 and 26 weeks. However, important questions regarding the appropriate timing, duration, optimal strain, and long-term outcome remain. To treat if you use probiotic to prevent level 2, stage 2 or 3 NEC, you need somewhere between 29 and 60 babies. Lactoferrin, as I said, is a very great immunoprotector of the gut, and human lactoferrin has been shown to be of benefit. Bovine lactoferrin has not been shown to be of benefit. So lactoferrin possibly one can use or not. Now, this debate about surgery, whether to give, a drain or laparoscopy, as you can see, these are figures from United States to 2017. The surgical NEC is about the same, whereas the medical NEC has come down. But mortality from surgical NEC has remained between 20 and 30%, 35%, whereas mortality from medical NEC is between 15 and 20%. whether to drain or do laparotomy. When I was as an associate professor at Sick Kids in Toronto in 84, 85, the chief of surgery, Edmund Ein, started putting drains in. And at that time, the drains were not very popular, but drains have started becoming popular. And in 2017, in fact, there is more drain than laparotomy. And in the 2021 last year, this is from Blakely, American figures, there's hardly any difference between doing laparotomy or putting a drain in first. The surgeon, it depends entirely on the surgeon's team. A very small study from UC Davis has shown NDI then left, but this study is very, very small, of only 94 babies. We all know the complications: abscess formation, short gut, neurodevelopmental delay. And one thing I want to point out, if you have a very preterm baby and you do surgery early, the recurrence is possible, because if you do it in the time period when the TLR is still rising, you are likely that you may get recurrence. And so don't be surprised if you do surgery very early on in very preterm babies that you get recurrent NEC. Long-term complications, high, morbidity is high, much more so in surgical NEC than in medical NEC. So, my friends, at the end of all this, the clinical diagnosis is unclear, clinical marker of NEC, and the treatment has remained unchanged from the 60s. So it is a little surprise or a little wonder that we as clinicians overdiagnose and overtreat NEC. And that is going to happen till we get more accurate diagnostic tests, until our therapies are much more individualized to treat NEC. How about preventive? You need a large number of babies, each prevention strategy, whichever one you take, except these two, but these are based on very, very tiny babies. So prevention strategies essentially is trying to avoid formula milk, trying to avoid stress, trying to avoid hypoxia, and trying to avoid the immunoreactivity and dampen that down. And this has been done at Emory University, and that is the best approach, I think, and I can recommend that, is to do a quality improvement approach. And they have been able to decrease their base incidence from 8% down to 4% by doing quality improvement. And what they did was they reduced their time duration of indwelling feeding catheters. They moved on to, as quickly as possible, to use cup and spoon. They provided probiotics. They provided placental transfusion, i.e. delayed clamp cord, follow it. They increased the use of human milk, and if they were donor or human fortification, and they reduced totally zero the acid suppression. I think acid suppression drugs nobody uses them anymore. But the QI is the way to go forward at this particular moment in individual unit, because research results will take some years to come. So to summarize, if we can prevent prematurity, good early and exclusive use of breastfeeding, standardized feeding policy, consider use of probiotics, appropriate and as short as possible use of antibiotics. Make sure that there's enough arginine in your TPN, because it's a enterocyte protector. Agents to reduce that is TLR, but these are experimental. And surgery debate, whether we to do drain or surgery. Last two slides and I finish, I promise you. We have been late in recognizing that maternal milk and colostrum protects against NEC, but we have been late in recognizing that babies in utero do not get NEC. Why do they not get NEC? Because the amniotic fluid contains very similar things that we have in human milk and in colostrum, and thus the current research going on showing that amniotic fluid swallowed by the developing fetus inhibits TLR, so it reduces immunoreactivity and therefore increases the epidermal growth factor and therefore heals the gut much more easily and prevents it from developing NEC. Last but not least, there are two interesting studies which I found interesting. One is a use of polymer called hyaluron, which if you give it to the baby, it forms a layer, just like a mucinous layer, and it prevents translocation. And so that has been tried in animals and has shown good results. The other is a study from Italy, which I found fascinating, but don't understand it fully, but I need to review the literature more. Just about to finish there. Is that this is called remote ischemic conditioning, RIC. What they do is they have a sphygmometer and cause ischemia of the limb, upper limb for 30 seconds to 60 seconds repeatedly from time to time. And what they have shown is that during the period when there is ischemia, there is much more blood supply to the gut, and therefore they have shown that it reduces the incidence of necrotizing enterocolitis. I just found it fascinating. That's why I have put it. But I think the way forward is to find epidermal growth factor and human oligosaccharides, and for diagnosis is machine learning. So at the end, my friends, despite 60 years of NEC experience, lack of improvement, overall survival remains because due to lack of definition, specific diagnostic modalities, inexact and non-personalized treatment, and the bottom line remains in trying to control TLR and preventing death of the enterocyte. I'd like to thank you for your attention, and I'm sorry if I have not gone over time. I'm on time, so I'm ready for any questions. Thank you so much.
Thank you so much, sir. So moving towards the questions. So a few questions are here.
Yes.
One is, what is role of metronidazole in the NEC?
It's very debatable. Majority of babies who get NEC, the culture positivity rate and certainly anaerobic bacteria rate is very low. So when we started, excuse me, in the 60s and 70s, we used to use flagyl metronidazole routinely, but we gave it up a long time ago. We don't routinely use it.
Oh, sir, I think it is more because of the anaerobic to cover, and especially if they have a pneumatosis or the perforation.
Question, Junaid, you're absolutely right. But actually, the finding of anaerobic bacteria is very low in NEC, even when after perforation, if you look at the drain fluid comes out, it is very low. And so the use of metronidazole is as I said, debatable. Some people use it. We gave it up a long time ago.
Oh.
Right, sir.
Do you use it? Do you use it, Junaid? Do you use it?
No, we use actually we are covering the anaerose, but through other antibiotics like tazobactam, piptaz, So we are not.
So do you use tazobactam routinely in NEC?
No.
And Naveed, what do you do? Oh, Naveed is not there. I saw his.
Yeah.
Don't worry. I'm just asking what people do. As I said, we don't use it.
Yeah, we don't use routinely, but we see the very severity and the inflammatory markers and all those. Then we use.
Yeah, maybe that other reasons to use it, but routinely we don't use it.
Yeah,
So
routinely.
culture negative.
Sorry.
In spite of culture negative.
Majority of the time it is culture negative. It is very difficult to get culture positive.
Right. So second question is, can NEC occurs in first week of life in preterm babies?
Rare, very rare. As I showed you, the reason for NEC in very preterm babies depends on how preterm the baby is. If you're talking about a baby at 34, 35 weeks, then yes, it can occur in the first week. But if you're talking about really preterm babies less than 33 weeks, then it usually takes a week or two or longer.
Right, sir. So third question is, can we use probiotic to prevent the NEC?
Well, as I as I showed you, some people are using it in North America. Still, they are reluctant to use it. But even but Emory University and others are using it. It is used in Europe. I am trained a European trained neonatologist and practice in Europe. So I have been using probiotic. But again, we don't know which probiotic you're going to use, how long you're going to use, when are you going to start, and what strains should there be in your preparations. And of course, remember that most of the preparations are commercial preparations and not made for medical use. So it may have, and there have been infections secondary to probiotic therapy. So probiotic is not that simple.
Yeah, and just to add, Saeed, 1 minute, inshallah, on I think Monday starting Tuesday, they are going to present the latest data. If you know Dr. Richard Chandler in Hot Topics about probiotics. So inshallah, we will update you.
Right, sir.
Thank you.
Sir. So moving towards next question. Can donor milk cause NEC?
And what?
Donor milk.
Donor milk can cause NEC?
No. Milk is protected. Human milk is protected. What I said was that donor milk, because it is coming from mothers who actually deliver a term, has got less oligosaccharides than the preterm milk coming from mothers who have delivered preterm. So it is protective. But if you have a milk from a preterm mother, it has much higher oligosaccharide levels and it's much more protective.
Right.
Wait, 1 minute, Said, because I don't forget. Sir, you said that the animals don't have HMOs.
The specificity of that's correct. The vegetables have some related NEC oligosaccharide, but human milk oligosaccharides are unique to humans.
Yes. So you know, now all the formula companies adding the HMOs, and this is the laboratory make HMOs. So what do you think about those HMOs?
The evidence so far is that this is just a ploy.
Okay. Go ahead, Said.
Okay, sir. So moving towards another question. Any role of omeprazole in NEC?
No.
Any role of?
Any role of
what, Junaid?
Omeprazole
in NEC?
PPI, proton pump inhibitors.
Not at all.
Not at all. Yeah.
Right, sir. So Dr. Navi.
Sajjad had raised his hand. Anyway, go ahead. Go ahead, Said. Please go ahead.
So another question, Dr. Naveed comment is we use metronidazole. Our surgeon love it.
Well, the surgeons love many things, but we are not quite sure that we love it that much.
And you know that practice is also very old. That 7 days NPO and continue antibiotic for 7 days. You know, so if you have a feeding intolerance, and let's say whatever the stages or whatever the grading you are using, the grade 1 or stage 1 NEC, just put them an NPO, relax the gut. That's more than enough. You don't have to start antibiotic unless until other parameters are okay.
Indeed, I mean, and that also, Junaid, the longer you leave the NPO, the bad it is.
Exactly. This makes the nurses and everybody so anxious. So we usually do 3 days to 5 days, and then we will see. Yeah.
We have done it. We have done it for 5 days for many years, and we start trophic feeding after that.
Exactly.
Hello. Can you listen to me? Assalamu alaikum. Can you listen to me?
Yes, I can.
Yeah, thank you very much for giving me the opportunity. It was an excellent review of the subject. And I'm just requesting you if you can kindly put it as a review article. and
Okay.
we'll be happy to publish it in the Journal of Clinical Neonatology.
Okay, I will do
This
that.
will be very good for the profession in large. And
Inshallah.
we had a similar presentation in the Saudi Neonatal Conference, 2 presentations, and
I did mention that. I did mention that, Joseph knew, yes.
And one of them was about the diagnosis using the ultrasound, which is, of course, it's a new area which we all need to learn.
As I said, ultrasound is very good, but it is operator dependent. And
of course, we need training.
Yeah.
That's the basic bottom line. Now, the other issue is about this machine diagnosis. Can you kindly explain this a little bit more to understand?
Yes, what they do is, what is done is that you take a large database from many units. For example, if you take the database from all the women, Oxford network database of cases of NEC, you then write down and all the variables which you can think of, and then you try and analyze each variable in relation to development of NEC. Only a machine can do that. And once that is done, you will then find that a machine can actually narrow it down to 4 or 5 things. And that will then be able, and that machine, if you put those 4 or 5 things, that will give you whether the diagnosis is NEC or SIP or something else. I think
so. What exact
Joseph
data this machine needs?
Oh, hundreds of data. Actually, I can send you, Sajad, a paper on that, because the data collection is massive, and the companies are spending millions collecting data from thousands of units because it has to be validated. It has to be very machine can learn once you feed it something like thousands and thousands of data points. It then analyzes that.
But then that is not something useful for individual patient care.
Not at the moment, but once they get down, for example, the different Son paper in Nature this year, they have been down to only 5 things. So you can actually NEC and SIP. So it will come in greater use over time. At this moment in time, it is just a research tool.
Yeah, thank you very much. And that's the last thing is that the 2 or 3 beautiful slides which you showed about the role of breast milk in reducing the incidence of NEC. Can you kindly post it in the group as individual slides? I would like to use this to educate my nurses.
Sure.
Thank you very much.
No problem.
I appreciate that. It's a wonderful presentation.
Thank you
very much.
Thank
you, sir. So moving forward, so another 3 questions are here.
Yes.
One is role of plasma transfusion in NEC.
Role of
plasma transfusion.
FFP.
FFP. That is a difficult one. Why would you use FFP in NEC?
Yeah, I think they are asking because if it is a very severe and the stage 3 NEC with the thrombocytopenia with the tinge of sepsis, so maybe that's why the coagulation studies.
But Junaid, that is the treatment of not NEC, but shock or complication of hemodynamic issues.
DIC actually, coagulation and all those.
Yes, it is not a treatment of NEC. It is a treatment with complications.
Right.
So with the complications, yeah, that's the thing.
Another question from Dr. Maqbool Qadir, sir. If the definition is not universally acceptable, then how can we trust the beta analysis from the different units with different definitions?
Quite big problem, Maqbool. As usual, you have to do throw a spanner into things. Yes, of course, it is very difficult, and that is the reason why comparative studies as far as NEC is concerned is extremely difficult, because if we can't define something, then how do we compare with each other? So if somebody is calling an apple an orange the same, it can't be the same. So yes, you're absolutely right that there's a huge issue about definition, and you can only compare if people are using the same definition at that time. So you really have to just take it at that. That is how it is. There is no unified consensus definition of NEC.
Yeah.
Right, sir. So another question is from Dr. Aisha Rafiq. She's asking, sir, I have a question from Dr. Aisha from CMA Lahore. We have a baby with 35 plus 5 weeks.
Yes.
With history of prom for 20 days. Initially treated for early onset neonatal sepsis for 2 days, and antibiotic stops as culture was normal. Vitally stable. On 5th day of life, he developed abdominal distension and aspirate with raised CRP of 123, and CBC shows, gas shows -7 base deficit, and he was on express breast milk, and feeding started at day 1st postnatal life. X-ray abdomen shows showing dilated gut loops. Should we label it NEC?
Not just yet. Yeah, if you have abdominal distension and distended loops with a history of prom, that's much more likely to be a baby who has sepsis rather than NEC. And I know the culture was negative, but you have a very high CRP. Now CRP rises in NEC, and it can be very high. The question is, I personally would, I don't know what Junaid thinks, but I think that baby is much more likely to have sepsis rather than NEC.
Yes, I think it's like a chicken or egg, but I think in this case is the sepsis, which is causing the abdominal distension and the gut, the loop dilatations. Yeah.
But sir, here is one query. Sepsis is also one of the risk factor of the NEC. So
yes, sepsis. It is, as I said, as I showed you, the 3 arrows of in the breastfeeding slide. Giving formula, and this baby did not get formula. I know Dr. Saiba has said the baby was given breast milk, but if you see that giving formula milk increases NEC, increases surgical NEC, and increases sepsis. So this is sometimes very difficult to differentiate without actually being on the bedside to differentiate between NEC and sepsis. And from the data which you presented, just because there is abdominal loop distension, I would not label it as NEC. Is there any thrombocytopenia? And again,
sir,
if there was thrombocytopenia, whether it's gram-negative infection or not, I don't know. It's very difficult.
Can you allow me? मैं तलाल बोल रहा हूँ जी सर. मैं इसमें 1-2 चीज ऐड कर सकता हूँ, दिस केस जो है ये मेरे यूनिट से डिस्कस हो रहा है, इसलिए am I allowed to speak?
Sure.
Of course. You're a free man.
Sir.
Free man, free country.
बिल्कुल. So kind. But it's very grateful. What a fascinating talk. Honestly, absolutely as usual, sir की talk is absolutely fascinating. सर मेरा एक बहुत नाइव सा सवाल है जो कि हमारे सेटअप में I am 100% sure you visit Mayo Hospital, you visit any I'm talking about TGH or anywhere, a 30-weeker born, he has, okay, let's first discuss it. He is, because mother is not available at that point in time, we don't have TPNs, we can't put the baby on a long-term TPN. Unfortunately, we put him on a formula feed, day 4 of life. I'm talking about a 30-weeker in the context of this thing. Aapne sir ye kaha कि preemies don't have NEC in first week of life. हमने उसको formula feed पे शुरू किया मजबूरन, and the baby develops abdominal distension. he has abdominal distension worsens, there is thrombocytopenia, the abdominal X-ray shows first dilated gut loops, and after about 28 to 48 hours, it worsens to that extent that there is paucity of air in it, and progressively it becomes a complete whiteout sort of a abdomen. What pathology are we dealing with if you say कि ये NEC नहीं है first 1 week of life में? This is the most common scenario faced in our setup. Sir, please.
Right. देखिए Talal, it is very simple to explain that. When I say that you don't get NEC early in a 30-weeker or so, that is the usual norm. Now, what happens in this particular baby, you have possibly an evidence, and this is very difficult to say whether that baby has necrotizing enterocolitis. The reason I say that, as I showed you, is that you have to have necrosis in the gut to have a diagnosis of NEC. There are so many other variables which may be there. Now, you have a baby who's 30 weeks, you started formula, you don't know whether I assume the baby had no hypoxia at any time, and the baby always maintained, had a good Apgar score and a good oxygen saturation, then it becomes unlikely
sorry to cut you, sir. Sorry to cut you, sir. एक चीज, लेकिन unfortunately हमारे part of the world में ये black information, ये हमें information मिलती नहीं है, तो हम उसको फिर क्या label करें? You know what I'm saying and where I'm coming from is कि हमारे पास ये भी information नहीं होगी कि Apgars कितने हैं, हमारे पास ये भी information नहीं होगी background क्या है, ठीक है? So then देखें हम उसको I don't know, I've not been able to explain myself, maybe we can't go per operative. I know NEC जो gold standard है, that's only this kg आप necrosis देखें on per operatively, ठीक? So उसके बगैर फिर हम उसको feeding intolerance label करते हैं simply, and then we can't even differentiate it from sepsis. ये चक्कर है. Thrombocytopenia दोनों में होगा.
Talal, when we even have good history, we find it difficult to label some babies don't have good history, that it becomes even more difficult with that question, because if you don't have the available information, how can you make that diagnosis and give you an answer? I can't give you an answer to that.
अच्छा, जब
Can I have a comment as well?
Paucity of air आ जाती है, तो that stage.
Hello.
When there is complete paucity of air and there is a whiteout and massively abdomen distended, should we consider that this is really NEC? Probably नहीं है कि this is, it can't be sepsis then. Sepsis में इस हालत तक तो नहीं पहुंचती.
Abdominal whiteout is very rare in NEC.
हाँ.
Hello.
So then what are we doing? जी.
I have no idea what you're doing. I have no idea what you're dealing with, because you don't have.
Sir, but this is the common scenario. This is the commonest scenario everywhere.
Scenario to hai. Talal, scenario to hai. But why do you label something when you